aneurysm it's kind of like a blister that forms off of a healthy blood vessel. And they typically form when you have a blood vessel branching into two what we call daughter vessels. So you have a parent vessel and two daughter vessels, and that bifurcation, that area where you have a split, that's where an aneurysm will typically form. That's not the only place they form, and it's a weakening of the blood vessel wall that just balloons out. So you can imagine when you have an overinflated balloon, you get these little blebs that kind of form off of it, and they're a weakness in that balloon, and that's basically what an aneurysm is. So because they're weak, they're at risk of rupturing. We don't know what causes aneurysms. There are risk factors for aneurysms, so there are some that are modifiable and some that aren't. Risk factors are female gender. So if you look at all comers with aneurysms, about 60% of them will be female. There's a risk for aneurysms when they run in families. So there are certain familial disorders that carry aneurysms as one of their traits, but also just having aneurysms can run in families. So if you have a first-degree relative with an aneurysm, that puts you at risk for having one. Smoking is a very significant modifiable risk for aneurysms. And then for people who have aneurysms, high blood pressure, uncontrolled hypertension is a risk for those aneurysms rupturing, as is, again, smoking. So typically aneurysms don't cause symptoms unless they pop, which is why they're tricky. One of the things that I always tell patients that I'm at a little bit of a disadvantage for is that patients don't come into me with an unruptured aneurysm having some kind of pain that I can treat. So they're not going to feel any, if I do my job properly, they're not going to feel any different when I'm done, than when they did when they came in. Than the way they did when they came in. Sometimes people have headaches and aneurysms will be found because they're having headaches and they end up having imaging for it, but treating the aneurysm is not going to treat the headaches. So very often aneurysms do not have any kind of outward presentation unless they pop. When they pop, it's very dangerous. So when an aneurysm ruptures, about 50% of patients won't make it to the hospital alive. So the patients that do get to the hospital are usually not in a great place. Sometimes they come in, they look really good, they just have a bad headache or a moderate headache. More oftentimes though, they're a baseline level of consciousness. So usually their consciousness is depressed, they're quite altered, severe headaches. Sometimes they can become unresponsive, sometimes they come in a coma. Certain aneurysms can cause symptoms based on their proximity to other structures within the brain. So a common aneurysm is a posterior communicating artery aneurysm. And posterior communicating artery aneurysms are right near something called the oculomotor nerve, and they can actually cause a palsy in that nerve. They can also cause a palsy in the third nerve, which can cause problems with how your eye moves. If you're lucky, those will present with that rather than a rupture. There are other aneurysms in the posterior circulation near the brainstem that can get so big that they can start pushing on the brainstem, can cause problems with swallowing, cause problems with dizziness. Unfortunately, those are also very tricky ones to treat, but those are really the exception, not the rule, that you're going to have an aneurysm that has not ruptured that presents with some kind of symptomatology. What I tell my patients is we have 3 avenues to go down. You can either do nothing, which frequently is the appropriate treatment for some smaller aneurysms, especially in an older patient. And then your 2 treatment options are an endovascular approach or an open approach. So the open approach, which is the classical way that we treated aneurysms for decades and decades, is an open surgery, microsurgery. So that's when you actually have to make an incision, cut off a piece of bone goes back at the end, but split the brain, find the aneurysm, put a titanium clip across it, and then close up. The endovascular approach, I either put a catheter through the radial artery, which is in the wrist, or the femoral artery, which is in the leg, put the catheter up into the neck, and then I take smaller and smaller catheters up until I get into the aneurysm and put platinum coils in. Sometimes I have to use a stent, sometimes a combination of the 2, and then there's some new devices. But in general, the 2 theories of the endovascular approach, you're either going to divert flow away from the aneurysm with a stent, or you're going to put coils into the aneurysm to get flow out of the aneurysm dome and protect that aneurysm from rupturing.